So I'm going to fly through a bunch of slides here. Lot in these. You may want to pause on some of the charts. You can easily find these online as well. A lot of information in them. I'm just going to hit the highlights. So big thing, type 1 versus type 2. Type 1 is autoimmune. Generally, there's little or no production of insulin. So essentially, all type 1 diabetics are on insulin. Rarely are other medications used along with them, and we're not going to talk about that. Type 2, again, we stopped using Roman numerals about 15 or 20 years ago, but it really refuses to die. You look a lot more informed and professional if you use type 2 with the Arabic numeral rather than the Roman numerals, but you will see a lot of professionals continue to use type 2 with the Roman numerals. That is what a lot of us were taught 30 or 40 years ago. That is no longer current, but still used. Type 2 is very different. It's a case of insulin resistance. They decrease production of their insulin. They develop, substantial resistance to the insulin. Type 2, again, is almost always unrelated to diabetic ketoacidosis. Most people with diabetic ketoacidosis are type 1s. Type 1s get DKA because they are not producing any insulin, and therefore their sugar can't get into the cells, and there is no normal sugar metabolism. Therefore, you produce fat metabolism, which produces ketones, which is why it's diabetic ketoacidosis. So we do sometimes use basal insulin in type 2s. If you have somebody that you're having a really hard time controlling their diabetes, you sometimes put them on a low grade 24-hour type insulin like Lantus or Levemir, but that's not exactly the norm. We don't usually do that very often. I had a patient once that thought it was basal, like the plant in the garden, but no, it means a basis, the normal low-grade insulin that you always have. Other medicines, biguanides, which basically is metformin, and metformin decrease the conversion of precursors to sugar in the liver, and therefore decrease the amount of sugar in the bloodstream. They also have some other, they're probably sensitizing, they have some other positive effects. You'll lose a few pounds with them. They're very good medicines, but they do have some downsides as well, which we'll talk about probably in the next talk. Hypoglycemics, which are also known as secretagogues, which are the sulfonylureas and the meglitinides, are basically something that squeeze the pancreas. Not literally, but figuratively, they squeeze the pancreas to have it put out more insulin. They're eventually going to run out. They're not going to last that long. They're associated with some weight loss. Check that, some weight gain. That's a major issue with the sulfonylureas, is they have weight gain. They are cheap though, so a lot of the insurances insist that we use those as first line. GLP meds are great medicines. They're relatively new advances. DPP4s are the enzyme. DPP4 is the enzyme that breaks down GLP-1, so that if we block that DPP4, we'll increase the amount of circulating GLP-1. They're not quite as effective as the actual GLP-1s. The only problem with the GLP-1s is they all have to be injected. Good news is they're tiny needles. They're associated with some weight loss. A lot of patients actually do really well on them. DPP4s don't have a whole lot of evidence for long-term good outcomes. Glitazones are medicines that decrease resistance, and these are medicines that, again, are used more, probably can be used in a type 1, but again, we're not going to talk about that right now. We'll also see those used sparingly because several of them are associated with liver problems. Pioglitazone, which is about the only one that we currently use, does not seem to have those liver problems, but many of us are still fairly cautious with it. It is fairly inexpensive though, so it is a nice choice for people that you're trying to keep the cost down. And at the very end of this talk, I'm going to show you a slide that is the newest set of guidelines from the Diabetes Association associated with not only what medicine you want to use, but what your objective is in using that medicine. The incretin agents, the GLP-1s, the DPP-4s we just talked about up above here. SGLT2s are newer medicines, which I'll talk about in a minute. So what are SGLT2s? Basically, there's an enzyme in your kidney that tells you to reabsorb sugar. And so if you block that enzyme, you actually start to pee out large amounts of sugar. They also seem to have some cardiac benefit. They have some weight loss. This is Jardiance and Farxiga and Invokana. There does seem to be some question of whether there's slightly increased risk of amputations, but I think that this risk is pretty much overblown. But unfortunately, once these things get in the media, they get picked up on. So types of insulin. So this is a chart that you're probably going to spend a fair amount of time really trying to understand. The rapid acting and the long acting are the ones that we really count on at this point. So the Novolog, the Apidra, and the Humalog are the ones that you take immediately after a meal to cover your meal that you had. The long acting are the ones that last 24 hours or so. And they last, in a very level way. And so these are really the mainstay. The rapid acting are great for pumps, and you can respond very quickly and give yourself very small amounts of the rapid acting all day long. But lots of different ways to give insulin. So Afrezza is another way to give insulin, and that's an inhaled insulin. It's been approved for about 5 years now. I'm seeing a few patients that are using it. It's almost always under the supervision of an endocrinologist. There's some people that are using it associated with mealtime insulin coverage. Most of these people do not have asthma, do not have respiratory issues. And as I say, it's being used more, but I'm still not seeing it used commonly. Okay, so for type 2, who is type 2 diabetic? So a person who is older, usually, a person who is obese, usually, and those people start to develop insulin resistance related to that obesity. And so you check their fasting sugars, and if you get 2 above 125, or if you get an A1C above 6.4, those people meet the criteria for being diabetic. The 2-hour postprandial glucose, if you do an oral glucose tolerance test, almost never do we do those anymore except in pregnant women. And so those women would have pregnancy-related diabetes or gestational diabetes. And the other thing that can give you evidence of hyperglycemia or evidence of type 2 diabetes is if you have symptoms of hyperglycemia with a blood sugar greater than 199. Most people don't have any symptoms with hyperglycemia until it gets to be in the 300 to 400 range, though, and then they start to feel drifty, they start to feel off. Type 1 diabetics will actually have signs of hyperglycemia. They'll feel tired, they'll feel confused, even at those lower blood sugars. So again, reminding us that type 2 is very different. The beta cells are still producing some insulin. And so therefore, since they're producing some insulin, some sugar is getting into the cells, and therefore the cells do not have to turn on their fat metabolism, their anaerobic metabolism. And so therefore, rarely do you see DKA in a type 2 diabetic. Most type 2s, as we say, are overweight. The cells are resistant to insulin, and we just talked about the DKA. So other things, again, reviewing oral therapies, the hypoglycemics increase insulin secretion. They squeeze the sulfonylureas of the meglitinides. You won't see the meglitinides used anywhere near as often because they're a lot more expensive. Although if you have people with allergies to sulfa, because sulfonylureas by definition have sulfur in them, we may use a meglitinide. The glitazones decrease resistance. The gut enzyme blockers. The problem with gut enzyme blockers is they cause a lot of gas, and so rarely will patients do them. One exception is if you have somebody that has a need for like a DOT card. They drive a truck and they need to have approval from the Department of Transportation. Sometimes they will do this because those people, if they are put on insulin, that is an automatic denial of a DOT card. People that are on insulin can't drive big trucks. Is it discriminatory? I'll leave it up to you to decide that. Biguanides, as we say, that's metformin. SGLT, sugar passes through the kidneys. GLP-1 has a number of different activities, including appetite, including gastric emptying. I will leave it to you to review in your book the functions of GLP-1. Colsevelam is it's a gut blocker. Basically, it absorbs the cholesterol in the gut. I'm sorry, not the cholesterol, the sugar. It also does absorb cholesterol, which is actually an interesting effect of it. The problem with it is that it has a modest effect on the A1C and no real benefit as far as heart attacks, as far as the cholesterol. Bromocriptine is another thing that decreases hepatic sugar production. Again, it's a hormone blocker. It's something that's fairly expensive. Mostly, we only need to remember that if we're using it for something else. The glutamides, as we say, the Starlix and the Prandin, fairly expensive, but a good option if you have allergies. So this is the guidelines from the American Association of Clinical Endocrinologists from 2013. I think it's very good because it reminds you of what the choices are. So usually for monotherapy, essentially everybody is going to be put on metformin unless they can't tolerate it. Probably 20 to 30% of patients can't tolerate it because of diarrhea. Unfortunately, that is a very common side effect. And then they suggest using a GLP-1, a DPP-4, or the alpha-glucosidase inhibitors. These are great medicines. Again, unfortunately, insurance often doesn't let you do that, and they're fairly expensive. The SGLT2s are also a great choice for monotherapy or first drug, but unfortunately, they are also expensive, and so often we're left with that sulfonylurea down at the bottom. If you have somebody who has an A1C above 9 and they have symptoms, oftentimes we'll just start those people on insulin. If they have no symptoms, we'll either put them on double or triple therapy. So we'll give them metformin and a sulfonylurea, or metformin and a GLP-1. Either way, you want to try to get them down as soon as you can. On the other hand, some people, feel better if you bring them in a little bit more gradually. Unfortunately, there's a lot of people walking around out there with A1Cs of 13 and 14. So this is actually the newer version of that was put out in 2018. And basically, you'll see that there's not a whole lot of differences, except that we have moved the SGLT2 medicine up a little bit here. And we're also talking about, using basal insulin a little bit more as part of dual or triple therapy. So this is a great chart, I think, because it reminds you of what the adverse effects are of these things. So that if you have somebody and they have concern about weight, it is really helpful to focus on this line right here, right? And so you can see that metformin has a little bit of weight loss. You can see that the glitazones are going to have a little bit of weight gain. The sulfonylurea is going to have a little bit of weight gain. Insulin is also going to have weight gain. This is something that I think a lot of people don't know. And one of the reasons, and probably the biggest reason, that I'm very hesitant to put people on insulin. You have somebody come in, they have an A1C of 10, they're having some, times where their concentration isn't great. You can make a case for putting them on insulin right off. The problem is that when you put them on, they're often going to gain 10 or 12 pounds. So a lot of us will try to not use insulin if we can avoid it. But again, the guidelines do suggest that. You can see that for renal issues, the metformin is used with great caution with renal issues. There is some newer information on that, but obviously you want to make sure that patient's creatinine clearance is okay. For the GLP-1s, the Byetta, you do need to worry about. And again, there's lots of different medicines here and lots of different side effects. This chart is easily available online, and I would highly encourage you to study it. So just to remember, this is the usual amount of A1C reduction you get when you start somebody on a medicine. So if you have somebody who's got an A1C of 13 and you start them on insulin, you'll usually drop them to about 10. You'll usually get about 2.5 points. With diet and lifestyle changes, you can also get another 1.5, sometimes 2 points. But you do have to be careful trying to do that exclusively, because if you've got somebody with a very high A1C, clearly they're not going to get there without medication help. And so you can see that there's, substantial. The SGLT2s are not on here. You're likely to get a point and a half, sometimes even close to 2 points with an SGLT2. So something to think about. The GLP-1s can be pretty variable. They say only 0.6. I've actually seen substantially more than that. So this is the newest chart, and again, I know that there's a lot on here to digest. You will see this again. This is from the Diabetes Association. First-line therapy is always metformin. They're basically saying at this point we should try to decide, do they have any heart disease or kidney disease? So if they have heart disease or kidney disease, then you should probably try to go right to a GLP-1 or an SGLT2. Again, insurance companies are often not willing to play, even if you document that they have heart disease or kidney disease. But this is where the preference is going. Same thing as if you've got heart failure or kidney disease, start with an SGLT2. If you have a compelling need to keep away from hypoglycemia, they don't test their sugars, they're not very reliable on things, then a DPP-4, a GLP-1, an SGLT2, or a glitazone medicine, all of those rarely are associated with hypoglycemia, as is metformin. If you have somebody that you really want to lose weight, you can use a GLP-1. There's one of the GLP-1s, Victoza, that used at a higher dose, is actually approved as a weight loss medication. It's called Saxenda. Again, the other one will help you lose weight would be the SGLT2s. Unfortunately, because a lot of the insurance companies tell us we have to start with a sulfonylurea and a glitazone medicine, and oftentimes that's what you'll end up with is metformin, and then the sulfonylurea, usually glipizide, and then a glitazone, usually pioglitazone, and then only after they've failed all of those medicines and not achieved control can you usually get insurance to pay for some of the other things.